4, 5, 6, 7. We're good.
We're gonna start.
Yeah. Sophie, you ready? Okay.
We're gonna get started on time this morning. Welcome, everybody, to the Health and Human Services Committee room. I'm gonna first have committee members introduce themselves, and I'm gonna start way over on my left with Representative Lemelin.
That's because he knew my mouth was full. Hi, I'm Michael
I couldn't
Lemlin. I
even see your
represent House
donut.
District 53, which is Chelsea, Randolph, Piston, and Dresden.
Good morning, I'm Representative Dan Shigori. I just cleared my mouth. I represent House District 55, the communities of Holwell, Manchester, and West Gardner.
Good morning. My name is Julie McCabe. I represent District 93, part of Lewiston.
Good morning. I'm Representative Lucian Daigle, and I represent House District 1, the northernmost part of Maine. And I was reading up about words that are used to describe groups, and a swarm of bees is a swarm, and a group of crows is a murder of crows, and a group of vultures is called a committee.
Don't know how to follow that one, but good morning. My name is Flavia De Brito. I represent House District 64, which is part of Waterville and part of Winslow.
Hello, everyone. My name is Sam Zager. I represent District 116, which is part of Portland.
And Representative Griffin on Zoom.
Morning, everyone. My name is Abigail Griffin. I represent House District 34, which is Glenburn, Levant, and Cadeskeg.
Good morning and welcome. I'm Representative Michelle Meyer, serving Southern Maine's District 150, which is all of Elliott, where I live, and parts of Kittery and South Berwick. And I'm honored to serve as this committee's House Chair.
And good morning. I'm Senator Henry Ingersoll. I represent Senate District 32, which is the city of Biddeford and the towns of Arundel, Dayton, Lyman, and Hollis. And I'm the Senate Chair of this Health and Human Services Committee. This morning, I'll be presiding over the public hearing today. The purpose of the hearing is to invite testimony from members of the public regarding proposed legislation before this committee. And before I read on, I just want to make sure I'm introducing our analyst, Anna Broom, here this morning, and our clerk, Sophie Dubé. Today, the following bills this morning are scheduled to be heard. We're going to be hearing one bill this morning is LD 2154. The committee will hear testimony from people present and on Zoom who wish to speak for, against, or neither for nor against the bills being heard today. With the leave of the chair, committee members may ask clarifying questions of the person testifying today. The public hearing is just for that. It's for the public. The committee will have time for deliberation and debate at the work session that will be scheduled in the next few weeks. Whether you testify or not, you can submit written testimony to the committee. Please be mindful that testimony is public and available to all once it's presented. This hearing is live streamed and there is a recording of the meeting. Please silence all your electronic devices. If you're on Zoom, please be sure we're able to identify you when you are ready to take testimony from those attending virtually. If you're having any technical difficulties, please call our clerk, Sophie, at 207-287-1317. Some of our committee members serve on other committees, and you may see us coming and going today. You may also see committee members eating and drinking at the Horseshoe. The public is not permitted to eat, but you may drink water in the committee room. We'll take testimony from people in the room and on Zoom in the following order: those in support of the bill, those opposed, and those neither for nor against. The committee will give members of the public priority when taking testimony. Only the bill sponsor and the co-sponsors will be recognized before the public. We do run a 3-minute clock here on testimony. You'll see the clock at the front of the Horseshoe. As you're approaching your 3-minute point, please wrap up your testimony. If you have prepared testimony, please provide 20 copies to our clerk. You may leave those copies at the end of the Horseshoe to my left. Please sign in at the podium, and we thank you again all for joining us this morning. I'm going to open the public hearing now on LD 2154, an act to establish the Health Information Technology Fund to support a state-designated statewide health information exchange, presented by the bill's sponsor, Representative Drew Guttine of Westbrook. Welcome.
Thank you, Senator Ingerson, Representative Meyer, my colleagues on the Health and Human Services Committee. Always a pleasure to be here. I'm Representative Drew Gattine. I'm proud to serve House District 126, which includes parts of Saco, parts of Scarborough, and a part of my hometown of Westbrook. And I'm here today to present LD 2154, an act to establish Health Information Technology Fund to support a state-designated statewide health information exchange. This legislation seeks to create a platform for ongoing funding to safeguard Maine healthcare providers' access to information that they require to treat patients safely, while also unlocking a significant amount of federal funding at a 3-to-1 match rate. Beginning in fiscal year 26-27, what this bill does is it would create and fund a health information technology fund within the Department of Health and Human Services to support the operation and sustainability of the state's designated statewide health information exchange. And in Maine, that is Health InfoNet. And folks from Health InfoNet are here to provide more background in terms of what they do. Health InfoNet collects, stores, and organizes confidential medical information and records for 2.2 million people. This information is available to healthcare providers so that they can deliver care safely and effectively. It connects providers and is relied upon them, including hospitals, rural health centers, and other types of provider practices. Government entities also utilize and rely on this data to ensure that care is being delivered in a high quality manner. Maine Care, the Maine Center for Disease Control, the Maine Department of Corrections, the Veterans Administration all have access and utilize the clinical data within Health InfoNet's structure. Each day, approximately 9,000 providers utilize the compiled clinical data in the process of providing healthcare to their patients in Maine. So to give you a little bit of background as to why this bill ended up with you this year, because I know you guys need more bills, right? In last year's budget, the governor proposed a new per bed tax on providers, particularly hospitals, that use Health InfoNet in order to provide the funding to maintain the functionality of the system. There was a lot of strong objection to this proposal in the governor's budget, and ultimately we did not include that proposal within the budget. Basically asked the interested folks to go back to the drawing board and maybe come up with a proposal that was more acceptable to everybody involved. And Health InfoNet and the providers, including hospitals, physicians, and primary care practices, did exactly that. They went back and worked together and came up with the structure of the proposal that is included with this bill. So that being said, I hope this will get the committee's support. Again, I think we've got interested parties here, including Health InfoNet, to provide further detail about what this data does and why it's important to continue to maintain it. Thank you.
Thank you very much, Representative Gattine. Do we have any questions for the representative? Yes, Representative Daigle.
Good morning. Thanks for presenting this.
Yes, sir.
You talked about a 3-to-1 match. Is that ongoing?
I believe it is. Yeah. So I think the state has the ability to designate. Years ago, when the federal government really told states they wanted them to invest heavily into this type of IT to compile clinical data, they provided the opportunity for a 3-to-1 match. Health InfoNet is the entity that was designated by Maine DHHS to be that entity, which is why if the money flows in from certain sources, it's eligible for the 3-to-1. So I think the short answer to your question is yes, it is ongoing.
Thank you.
Any further questions? Yes, Representative Sager.
Thank you. The 3-to-1 match, is that endangered by anything in the last year at the federal level?
I wouldn't say that the 3-to-1 match is in danger. I think you're going to hear testimony about how the seed money is made available could have some impact on the 3-to-1 match. Okay. So the structure of states being able to draw, or entities like Health InfoNet to draw 3-to-1 match is not in danger.
Thank you.
Thank you very much.
Thank you.
Yeah.
I also, again, provided my my tribute to the committee.
Oh, boy.
Have a
Great.
feeling you're gonna be seeing me a lot over the next couple of weeks, and I want to stay in your good graces. So thank you for entertaining this bill this
So
morning.
much. Yeah.
Yeah.
I don't see any further sponsors in the room. Those in favor of this legislation, come right up.
Good morning. Chair Senator Ingwerson and Representative Meyer and honorable members of the Joint Standing Committee on Health and Human Services. My name is Sean Alfreds. I'm Executive Director and CEO of Health InfoNet, the operator of the state designated statewide health information exchange. We refer to it as the HIE. We live in acronym soup at Health InfoNet, so I'll refer to it as the HIE moving forward. I'm pleased to be before you today to testify in strong support for LD 2154, an act to establish a health information technology fund to support the statewide health information exchange. Health InfoNet, as many of you know and have heard from me before, is a nonprofit organization that was founded in Maine in 2006. Our HIE, we link individual health records, as Drew mentioned, from unaffiliated healthcare providers throughout the state to create a single patient health record that's accessible by all of our providers as we're receiving care throughout the state. We're governed by a number of state laws, including 22 MRSA, 1711C, federal laws, HIPAA, et cetera, and we're recognized as one of the national leaders in health information exchange. Today, we bring in information from a lot of different organizations, all the state's acute care hospitals, federally qualified health centers, a vast majority of outpatient clinics, behavioral health centers, social services agencies, community-based organizations, as well as Maine Care, Maine CDC, Maine Centers for Disease Control, Maine Department of Corrections, and the VA, among other sources. Currently, the HIE contains medical records for over 2.2 million people, both in-state and out-of-state residents, which are made available to healthcare clinicians so that to improve healthcare safety, improve healthcare quality, and improve the delivery of healthcare for patients. Today, as Drew mentioned, over 9,000 clinicians are accessing the Health Information Exchange and accessing over 250,000 unique patient records every month in Health InfoNet. Recognizing this, the Maine Department of Health and Human Services applied for and was awarded funding through CMS, Centers for Medicare and Medicaid Services, to sustain the Health Information Exchange. They awarded these funds based on evidence that the improved access to patient data and the HIE's management of that data have supported better outcomes and reduced costs across Medicaid, Medicare, and a range of public health programs. The CMS funding conditions are, which is a 3-to-1 federal state match, requires the state to provide the match. CMS directed that the state match must come from the state itself, not from Health InfoNet or the provider community. For FY 2025, the legislature approved $1.7 million in funding from the supplemental budget, while the state and Health InfoNet work to develop a sustainable strategy. DHHS brought forward a hospital bed tax, as Drew mentioned, last year, which was not approved by the Financial Affairs and Appropriations Committee due to concerns of inclusivity of stakeholders, as it was a hospital bed tax only, but also philosophical concerns around the tax itself. After that failed, the stakeholders got together, Health InfoNet, the provider community, other stakeholders that are obviously involved in Health InfoNet, to come up with a plan to propose a long-term sustainable plan for Health InfoNet to leverage this 3-to-1 match. LD 2154 is that. The fund, if seated by a direct appropriation, is only to be used for the state to draw down federal match from a 3-to-1 basis. And by doing so, all Maine providers would no longer have to pay a subscription fee to access Health InfoNet, thereby saving approximately $4.3 million a year for the provider community. Moreover, the investment by the state would reduce the barrier to small last mile healthcare providers. These are our smaller practices that we're still onboarding to Health InfoNet around the state. Cost is still a barrier, and it still costs money to connect their electronic medical records to Health InfoNet. Removing that cost could significantly improve their access to Health InfoNet and their ability to share data for all other providers to have access to it. So I've got.
I ask you to cut you short.
Okay, cut me short. So
we may ask you a question
yes,
after your
sure.
testimony stuff.
Sure, absolutely. So in closing, this is a way for our, this bill helps to save money for the provider community and creates a sustainable business model for funding the Health Information Exchange long term by gaining access to that 3-to-1 match. So I'll stop there.
And I have a question for you.
Yes,
Thanks
sir.
for your testimony. What happens if the legislature does not establish the HIT fund?
So if the legislature does not establish the HIT fund, Health InfoNet would have to continue levying fees. We call them subscription fees to the provider community. And those fees, as I mentioned, are about, to the provider community right now, is about $4.3 million a year. And that's continuing to go up as IT costs, security costs go up. About 30% of our budget is just security alone. So these costs are relatively high. We manage a medical record system for over 2 million people, as I said, but at the same time, it is a financial burden to the provider community.
Yes, Senator Moore.
So how much is the actual access fee? Is it based on the number of patients? Is it based on the size of the health center, or how is that developed?
Yeah, so the fees themselves are developed by starting with the number of patients. So we call it a per patient per year fee.
Okay.
But then larger organizations, we cap those fees at a certain level for larger organizations to have a level and fair playing field.
Okay.
And the state, and I should also add that the state of Maine and DHHS also pays fees for access. And so they put in their budget over $1 million a year to help support Health InfoNet. And then various projects that they asked us to do also cover our costs for developing those projects for Maine Care and CDC and other
Or
state
any
agencies.
changes that we ask to be made to the records and things like that?
Correct.
Gotcha. Thank you.
Yes, Representative Daigle.
What would that fee be for like an individual provider?
So
per
for an individual provider, the fees start, there's what we call an onboarding fee, which is the cost that it takes to create the network connection. So we have to create a secure network connection for that information to flow. And that varies based on the IT capability of the practice. So the practice has a strong IT team and they don't have to outsource that, then that's a lower cost, but oftentimes with these smaller practices, it's fairly high. We have to develop what's called a virtual private network connection and these other pieces. And then there's an annual fee on top of that. So the initial connection can range anywhere between $2,000 to $8,000, depending on what technologies they have in place. And then the annual fee per year tends to be $1.50 to $1.80 per patient per year, with a cap at the bottom, which is a minimum fee of approximately $800 a year, and then a cap at the top for the largest healthcare systems, as I mentioned earlier. You're welcome.
Yes, Senator Nangle.
Thank you. I'm Senator Tim Nangle. I represent Senate District 26. Good to see you again, Mr. Alphonse.
Good to see you.
Were you ever able to complete the integration with Maine EMS?
Today, we receive all EMS run reports, and those are in the exchange and available to all providers accessing Health InfoNet. We are working on a way to help integrate even deeper into the EMS systems themselves because they use tablets. That project is ongoing.
Great.
Yep.
Yeah, yes, Representative.
Thank you, Mr. Chair. Thank you for your time this morning. Do you have a sense of how many providers in Maine are not yet accessing the Health Information Exchange?
It's a tough number to come up with because we don't have a comprehensive list. This is something I'd really like to change. Just throwing that out there. But at this point, we know that we're connected to about 90% of all the outpatient practices. So there's about 10% plus or minus in there. Most of the large practices, all of the hospitals are connected. But there are a number of smaller practices, especially in rural Maine, that we really could use help connecting. And it's the cost side that really is their barrier. Yeah.
I had Representative Zager. And then Shiguri, and then Representative Lumlin. Oh, you're all set. Okay.
Thank you, Mr. Chair. My question's already asked.
Okay. Representative Lumlin.
Thank you. The onboarding fee, if this bill were to pass, is the onboarding fee gone, or is it still going to cost a small person $8,000 to access this?
Our goal is to get our budget covered. So when we put together our budget annually, we have we look at our capacity to bring on new organizations. And so that the goal here is to cover that cost as best as possible. Details, it depends on which practices. As I said, the variability of the cost is oftentimes unpredictable. Some practices, depending on the electronic medical record system or the IT systems they have in place, but the goal would be to fully subsidize that within the operating cost of the Health Information Exchange so that we can bring in these last mile providers, as I mentioned.
Any further questions? Seeing none, thank you so
Okay,
much for.
thank you all for
testifying.
your time.
You're welcome. Further testimony in support of this legislation.
I think it was a bit of a game of chicken back there, but I know. Yes, my name is Ann Sedlak. I'm the Director of Advocacy with the Maine Medical Association. I also work alongside the Maine Osteopathic Association. We're excited to be here today. I was waiting because I feel like I'm not that well versed on this, so maybe you can pause for questions. But we're excited to support LD 2154 today. I also have the Maine chapter of American Academy of Pediatrics signed on to this testimony as well, because they also believe it's really important. So it supports one of Maine's most important shared health care infrastructure components. Since 2010, the Health Information Exchange has securely connected hospitals and healthcare clinicians across the state, allowing them to access critically important information near real time. This shared system supports care coordination, improves patient safety, reduces unnecessary duplication of tests and administrative work, and strengthens public health reporting. As you heard, most clinicians are connected to the system now. As a fun story, I actually presented this bill to our legislative committee last week, and Representative Zager's office mate stopped me and said I could not do my job if it wasn't for this. Dr. Connolly. As you know, he's very enthusiastic sometimes. But I think it's true. Everyone nodded, and it was an easy yes to say that we should support this. As you all know, we're facing huge financial pressure in the state. And so I always think about that whenever we approach a bill with a fiscal note. But I think that this is important, especially around that federal match. So thank you for considering our thoughts. And I'm happy to take some questions.
Thank you, Ann.
Yes.
Thank you. Any questions? Seeing none.
Oh, thank you
Thank
all. I know.
Further testimony and support.
Hi, good morning, Senator Ingersman and Representative Meyer and distinguished members of the Health and Human Services Committee. My name is Melinda Kinney, and I'm here today on behalf of Martins Point Healthcare in support of LD 2154. Martins Point is a not-for-profit organization providing both direct healthcare services and health insurance plans. We offer Medicare Advantage plans throughout Maine. We also have 5 primary care health centers in Maine, 1 in New Hampshire, and we also offer a TRICARE Prime military health plan under the U.S. Family Health Plan across 6 states in the Northeast, providing health benefits to active duty family members and retired military veterans. It's a little bit of a mixed bag over here, hard to point. The Health Information Exchange is an important resource that supports our mission to deliver quality care to our delivery system patients. It offers a significant administrative efficiency benefits, as well as real-time access to patient data, which reduces the need for manual medical record requests from hospitals and providers. It also lowers administrative costs for all providers and offers faster access to clinical information for various care teams, which increases accuracy for patients who are often asked their medical history on multiple times. The access to this information can also decrease duplicative testing, often associated with additional out-of-pocket costs for patients. So collectively, these efficiencies support better care for our Maine patients, as well as efficiencies for the healthcare providers. So we ask for your support for this bill.
Thank you. Any questions? Seeing none.
Thank you.
Appreciate it. Further testimony in support of this legislation.
Good morning, Senator Ingerson, Representative Meyer, and the members of the Joint Standing Committee on Health and Human Services. My name is Megan Stewart. I am the Director of Government Relations at the Maine Primary Care Association. The MPCA is a membership organization that represents Maine's community health centers, also known as the federally qualified health centers. Maine CHCs make up the largest independent primary care network in the state, providing high quality and accessible primary and preventative medical, behavioral, and dental health services for over 200,000 people at more than 100 service delivery sites in all 16 Maine counties. Maine's community health centers rely on the Health Information Exchange, which I will also refer to as HIE for the remainder of my testimony, as a critical tool to coordinate care, enhance patient safety, streamline public health reporting, and reduce unnecessary duplicative testing, saving both time and money for patients. The HIE ensures that when a patient undergoes testing or treatment, their medical record is updated in near real time for all providers participating in the HIE. For example, if a patient who typically receives care in York travels to Bangor and seeks treatment for a cough at a local health center, a chest x-ray taken there can be shared through the HIE. If the health center participates in the HIE, this would allow the patient's primary care provider to receive the results and promptly coordinate appropriate follow-up care. The HIE is an essential tool for supporting positive health outcomes, which is another reason why it is so critical that more physicians can use it. The Centers for Medicare and Medicaid Services has already recognized the importance of the HIE to Maine residents by awarding Maine's 75% of the HIE's operational costs, but they must receive the 25% match from the state. Passing LD 2154 will support the CHCs and healthcare organizations across Maine as they face growing financial pressures from the rising costs. During a time when all expenses are being scrutinized, it is vital that the HIE continues to be utilized by as many healthcare providers throughout Maine as possible. For these reasons, we urge the committee to support LD 2154. And I'm happy to take any questions.
Thank you for your testimony. We have any questions? Yes, Representative Zager.
Thank you very much for being here. What could the FQHCs at 100 sites in all 16 counties do with the money that you would not be spending on?
Ooh, that is an
HIE?
excellent question and one I will have to get you in the work session.
Okay, thank you.
Sorry about that.
Yes, Senator Nangle.
Just a quick one, and you may not know the answer, but somebody in the audience might. Are patients able to opt out of the system if they're concerned about privacy and?
I believe so, but yes, that would be a question for
Okay.
someone in the audience. I apologize.
I think we got it.
Got it.
Yeah.
Any further questions? Thank you for your testimony.
Thank you.
Any further testimony in favor of this bill? Jeff has written testimony. I have to let him know.
Senator Ingerson, Representative Meyer, members of the committee. My name is Jeff Austin. I'm here on behalf of the Maine Hospital Association to speak in favor of the legislation. I think this is my first time before you this
It
session.
is.
It's good to see you. And I have written testimony.
I just thought you were ignoring us.
I will be quick with our testimony. Hospitals were very early adopters of Health InfoNet, saw the value of it early. We're essentially founding members of Health InfoNet. We are represented on the board of Health InfoNet and are fully invested in its continued success. We appreciate that the state has, this is not new. The state has made investments in Health InfoNet in the past, and we're just seeking to continue those investments. It is a very important resource for us, and we would like to see it continued. Yes, people can opt out, as I understand it. So we would really appreciate you finding the ability to continue to support Health InfoNet as you have in the past, so we can continue to use it for the benefit of your constituents and our patients. With that, I'd be happy to take any questions.
Thank you for your testimony, Jeff. Any questions for Mr. Austin? Yes, Representative Lemlin.
No question. Not only is that your first, but it's your shortest ever.
They generally don't let me testify in favor of things. They generally keep me out there until it's, so. Thank you for noting that.
Yeah. Thank you. Thank you, Jeff.
Thank you, Senator.
Any further testimony in support of this legislation? We do have, yes, we do have one Zoom testimony in favor. Jessica Taylor. Glenburn, Maine, St. Joseph Healthcare.
Yes, good morning,
Welcome,
everyone.
Ms. Taylor. Yeah, we do. Welcome. We do have a 3-minute clock here, just to let you know and ahead of time. And anytime you're ready to start, go ahead.
Wonderful. Thank you so much. Can you hear me okay?
Yeah.
Wonderful. My name is Jessica Taylor, and I've been a registered nurse for 25 years. I live in Glenburn, and I work in Bangor at St. Joseph's Healthcare, Maine. And I wanted to share some, I'm boots on the ground. So I'm one of the clinicians that's using this tool in my day-to-day work to help to support patients in the community. So I wanted to speak to that and share just 2 brief stories and some information regarding that. Of course, you can imagine that I'm here in support of LD 2154. As I mentioned, I'm a nurse serving, very vulnerable populations in a rural area of our state. Bangor also serves patients in Aroostook and Washington County as well. For several years, the Health Information Exchange, I have seen how it's directly improved patient care, particularly for those who are medically or socially vulnerable within our community. The Health Information Exchange allows providers, as you have heard from others, immediate access to real-time patient information, including comprehensive histories, recent imaging, laboratory studies, consults, and notes from the community-based team, as well as advanced directives and the patient's goals for care. These integrations ensure that patient care provider team are informed, the care is accurate and consistent as patients transition through our community, our state, and healthcare, different healthcare locations. For instance, when a patient presents the emergency department, the HIE gives the care team instant access, as you heard, to allergies, chronic conditions, EMS reports, and patient-centered care plans. The information is especially critical for those who are unable to communicate. Lots of time, folks come to the emergency room and they're not able to communicate their health history. I could share countless stories about the benefits I've seen since working with folks since 2011 in many different settings, including street medicine, our hospital, and ambulatory space. But a couple I'd like to share, I think, represent a lot of the Mainers that we're seeing in our community. We recently had a local self-employed carpenter without insurance who had some health conditions and concerns, went to his provider, had some tests and imaging done, and unfortunately later in the day and the next morning had to show up in the emergency room for care. Because the providers were able to see those recent tests and results, they didn't have to duplicate and run a whole new series of tests for him. They had that real-time information at their fingertips. It saved him thousands of dollars. It also encouraged him to seek and continue to seek care. Another patient story is we had an elderly patient arrive with her neighbor, confused and not able to communicate well. Because of the HIE, the team that was taking care of her was able to access notes, particularly from her specialty oncologist in Southern Maine. So we were aware of that, that care being provided, but we were also able to see her current regime, which helped to ensure that her care was not compromised. It was not delayed. It was accurate. We were able to continue her treatment appropriately, view her medications, confirm her advanced directives, and most importantly, call her family and her
Thank you. Ms.
emergency
Taylor,
contact.
could I get you to cut your testimony short? We've got 3 minutes here.
Absolutely. Absolutely. Yeah.
Go ahead and conclude if there's a sentence you'd like to conclude with.
Yep, I just wanted to, impress upon everyone that this is not just a repository of data. This tells a patient's story and reflects their goals, their care team, and their support system as they move across the state, and ensures that their goals are of center of care. So thank you very much for considering this as legislation.
Thank you. Does the committee have any questions for Ms. Taylor? Seeing none, thank you very much for your testimony. Any further testimony in the room in support or on Zoom? No. A testimony in opposition? Seeing none. Testimony neither for nor against? Seeing none. Any request for the analyst for further information? Yes. Senator Moore.
In looking at the department's testimony, I know they submitted it neither for nor against. They make reference to the Rural Health Transformation Program. So I think it would be good for us to have a little bit more information about that, because they're kind of suggesting we use that, using those federal resources from the grant rather than committing an ongoing general fund. So I'd like to see what that includes and how much that is and what.
Sounds like something the
the-
department could come back with for the
Correct.
work
Yeah,
session.
to give us more information.
Okay,
So,
good.
thank you.
Any further information requested? With that, thank you. I'll close the hearing this morning for this bill. And we're not scheduled to go back until 1 o'clock, it looks like.
Yep.
Hey, I have a question. for you.
Yeah.
We just had a request from Senator Prohaski to meet with us for a few minutes.
Yeah, I saw that.
So if I'm busy tomorrow, I'm wondering if you got any time between now and.
Yes.
when I can reach out.
Yeah, but let's just agree that we're not going to agree to any crazy ideas that
No,
Ross
no,
has.
just listen.
Okay, sounds good. Yeah, I can make myself, I've got nothing in between.
Thank you, Michelle. We're removing the bottle.
Good.
Oh, this is.
Yes.
You can get started. I'm just going.
Okay.
Righty.
Good afternoon, everybody, and welcome to the Health and Human Services Committee room. We'll be hearing 3 bills today, and before we get formally started, I'd like the committee to introduce themselves this afternoon. We'll start over on my left with Representative Lemler.
Good afternoon, everyone. I'm Michael Lemlin. I represent House District 53, which is Chelsea, Randolph, Pittston, and Dresden.
Hi, I'm Representative Dan Shigori. I represent House District 55, the communities of Hollowell, Manchester, and West Gardner.
Good afternoon. My name is Julie McCabe. I represent District 93, part of Lewiston.
Good afternoon, everyone. I'm Senator Tim Nangle. I represent Casco, Raymond, Wyndham, Fry Island, and the best parts of Westbrook.
Good afternoon. I'm Representative Lucian Daigle. I represent House District 1, and I'll share the same information I shared this morning. A group of bees is called a swarm, a group of rhinos is called a crash, and a group of vultures is called a committee.
Hello, good afternoon. My name is Flavia De Brito. I represent House District 64, which is part of Waterville and part of Winslow.
Hello, everyone. My name is Sam Zager. I represent District 116, which is part of Portland.
Good afternoon. I'm Mary Ann Moore, and I represent Senate District 6, which is all of Washington County, along with 16 communities in eastern Hancock County, down East Maine.
And Representative Griffin joining us via Zoom.
Good afternoon. My name is Abigail Griffin. I represent House District 34, which is Glenburn, Levant, and Cadescag.
Good afternoon and welcome. I'm Representative Michelle Meyer, serving Southern Maine's District 150, which is all of Elliott, where I live, parts of Kittery and South Berwick, and I'm honored to serve as this committee's House Chair.
And I am Senator Henry Ingerson, representing Senate District 32, the city of Biddeford, and the towns of Arundel, Dayton, Hollis, and Lyman. And I'm very pleased to be the Senate Chair of the Health and Human Services Committee, and I will be presiding over the public hearings here today. Joining us today is our analyst, Sam Seneff, and our clerk, Sophie Dubé. Thanks for being here. The purpose of the hearing here is to invite testimony from members of the public regarding proposed legislation that's before this committee. Today, the following bills are scheduled for public hearing in this order. LD 2108 will be first, then LD 2123 and LD 2136. The committee will hear testimony from people present and on Zoom who wish to speak for, against, or neither for nor against the bills being heard today. With leave of the chair, committee members may ask clarifying questions of the person testifying today. The public hearing is just for that. It's for the public. The committee will have time for deliberation and debate at the work session that will be scheduled in the next few weeks. Whether you testify or not, you can submit written testimony to this committee. Please be mindful that testimony is public and available to all once it's presented. This hearing is live streamed and there is a recording of the meeting. Please, if you would, silence all your electronic devices. If you are on Zoom, please be sure we are able to identify you when we are ready to take testimony from those attending virtually. If you're having any technical difficulties, please call our clerk, Sophie, at 207-287-1317. Some of our committee members serve on other committees, and you may see them coming and going today. You may also see committee members eating and drinking here behind the horseshoe. The public is not permitted to eat in the committee room, but you may drink water here. We'll take testimony from people in the room and on Zoom in the following order: those in support of the bill, those opposed, and those neither for nor against. This committee will give members of the public priority when taking testimony. Only the bill's sponsor and any co-sponsors will be recognized before the public. We do run a 3-minute clock here in this committee room. You'll see the clock at the front of the horseshoe. As you are approaching the 3-minute point, please wrap up your testimony. If you have prepared testimony, please provide 20 copies to our clerk. You may leave those copies at the end of the horseshoe here to my left. Please sign in at the podium, and we thank you again for joining us today. And with that, we will start with the first bill. It's LD 2108, an act to establish the Suicide Mortality Review Panel. It's presented by the bill sponsor, Representative Stover of Booth Bay.
Good afternoon. Senator Ingerson, Representative Meyer, and distinguished members of the Joint Standing Committee on Health and Human Services. My name is Representative Holly Stover, and I'm honored to represent House District 48. Thank you for the opportunity to introduce LD 2108, an act to establish the Suicide Mortality Review Panel. I have sponsored this bill on behalf of the Maine Center for Disease Control and Prevention within the Department of Health and Human Services. As indicated by the title, this bill would establish the Suicide Mortality Review Panel, a multidisciplinary panel that would review the trends of death by suicide in Maine. If passed, this initiative would build on work led by the Bureau of Veterans Services and would include participation from the Department of Public Safety, the Office of the Chief Medical Examiner, as well as other key stakeholders. As you may know, we have several mortality review panels in the state. They each provide critical insight into the various topics they focus on. However, we do not have a similar group focus on death by suicide. This is needed as Maine sadly has one of the highest rates of suicide in New England. And I would also add, for veterans, Maine has the highest rate of suicide of all New England states. Within the recent establishment of the Office of Injury and Violence Prevention, we now have an office that not only has the expertise, but also has the capacity to take on this work. This bill is designed to help us collect needed data to better understand suicide in our state that will help to inform preventative policy changes in the future. I hope that you will join me in supporting this legislation. The department will follow with their testimony, and I ask that you have any questions that you might have for the department. Thank you for your consideration.
Thank you, Representative Stover.
Thank you.
We are going to call, I understand we have Jamie Bork here from the department. We'll call you up. Welcome.
Thank you. All right. Okay. Good afternoon. Senator Ingerson, Representative Meyer, and members of the Joint Standing Committee on Health and Human Services. My name is Jamie Burke. I do know it looks like Bork, but I promise you we pronounce it Burke. And I serve as the Director of the Office of Injury and Violence Prevention within the Maine Center for Disease Control and Prevention, part of the Maine Department of Health and Human Services. I'm here today to testify in support of LD 2108, an act to establish the Suicide Mortality Review Panel. First, I want to thank Representative Stover for sponsoring this bill on behalf of the department. It is being proposed as a step in a comprehensive planning process led by our colleagues at the Bureau of Veterans Services. BVS received federal funding jointly issued from the Substance Abuse and Mental Health Services Administration and the U.S. Department of Veterans Affairs to explore the feasibility of creating a suicide mortality review panel in Maine. Along with BVS, the planning group included participation from multiple offices across the state, as mentioned by Representative Stover. During our planning process, the Office of Injury and Violence Prevention within the Maine CDC was established. And through this process, the working group suggested that such a panel be established in Maine and that the newly established Office of Injury and Violence Prevention should be tasked with leading this work. Maine has one of the highest rates of suicide in New England, and suicide is the second leading cause of death for Maine residents ages 10 to 24. This bill recognizes the urgent need to create a systematic and data-driven approach to understanding suicide in our state. LD 2108 will establish a panel comprised of healthcare professionals, public health officials, first responders, individuals with lived experience, and other subject matter experts tasked with reviewing deaths by suicide. The panel will conduct comprehensive retrospective reviews of cases, examining contributing factors, identifying gaps in systems of care, and recommend changes or improvements to prevent future deaths. LD 2108 would grant specific authority to review data from multiple sources to build a clearer picture of the risk and protective factors within our communities. While Maine does have several existing mortality review panels that provide critical insight and analysis for public health threats, we do not have an ongoing group of experts focused on death by suicide. Other panels have been instrumental in identifying patterns, influencing policy, strengthening training, and improving resource allocation. Establishing a panel specifically focused on suicide will enable the state's prevention strategies to be informed by careful analysis. This bill provides the structure for that necessary analysis to better understand why suicides occur and how they may be prevented. The bill also provides thoughtful provisions for contacting next of kin. Families and loved ones often have critical insights into the circumstances leading to a suicide, insights that would not be captured through medical records or incident reports. This bill allows the panel to invite voluntary participation from next of kin in a way that is both respectful and trauma-informed, ensuring they are not compelled to participate, but rather they are given the opportunity to be heard if they so wish. It will also afford the opportunity of being connected to bereavement and mental health services. This will help reduce the long-term impacts of suicide loss, including elevated risk of depression and suicide among survivors themselves. Finally, LD 2108 includes a requirement for a detailed annual report with findings and recommendations that will be submitted annually to the governor, the Department of Health and Human Services, and the legislature. This will allow for both accountability and action. It creates a feedback loop, so lessons learned from deaths by suicide will directly inform improvements in prevention strategies, crisis services, workforce trainings, and cross-agency coordination. In closing, establishing a suicide mortality review panel is an evidence-based public health strategy that aligns with Maine's ongoing commitment to prevent suicide, and it has support across agencies and constituencies. I hope you will ensure that this resource is available to Maine by supporting LD 2108. And I thank you for your time and attention. I'm happy to answer any questions you may have, and I'm also happy to make myself available for you in the work session. Thank you.
Thank you, Director Burke. Do we have any questions? Yes, Senator Moore.
Thank you, Director Burke, for being here. My question, my understanding then that the department will be able to absorb the cost of this. There will be no additional fiscal note required.
Yes, ma'am. We will be able to leverage the staff that were included in the bill to create our office to allow this panel to function.
Great. Thank you.
Any further questions? Yes, Senator Nangle.
Thank you for being here.
Yes.
So I read the bill earlier and it talks about not contacting the family until 4 months afterwards. Will every suicide be evaluated whether the family agrees or not?
So that's something that we'll work out through the rulemaking process on how cases will be selected and what those criteria will look like.
Okay, thanks.
Further questions for Director Burke? Seeing none, thank you so much.
Thank you.
I'll now take further testimony in support of this legislation. Welcome.
Good afternoon, Senator Ingerson, Representative Meyer, and members of the Joint Standing Committee on Health and Human Services. My name is Lonnie Graham. I am a physician from Freeport. I am submitting testimony in support of LD 2108 on behalf of the Maine Medical Association and the Maine Osteopathic Association. The emergency preamble provides evidence for why establishing this panel is a good idea. Every year, 270 to 280 Maine people determine that their lives are not worth living, which is ample reason to try to understand why this happens. This is personal for me. In my family, 2 uncles and an aunt committed suicide. I remember every detail of each event. I watched my parents struggle to understand where they had gone wrong. blaming themselves for not seeing the signs. Rather rapidly, each death became something that could not be discussed or even mentioned. The deaths were described as unexpected in obituaries, but the pain never stopped. This has also affected me professionally. I've had few patient deaths that were more impactful for me. I have a clear and haunting memory of 2 young women who committed suicide. One of these was a 16-year-old girl who shot herself right here in Maine. That event was decades ago, but I can still see her in my mind. A suicide mortality review panel is a practical and evidence-based tool that allows us all to learn from such terrible deaths in order to prevent further future ones. Unlike vital statistics or aggregate surveillance data, a review panel examines the full context of each death, medical care, access to services, crisis response, family and school interactions, and broader social conditions. This system-level approach consistently identifies missed opportunities for intervention, gaps in coordination, and policy barriers that are invisible in routine reporting. The purpose is not to assign fault, but to translate tragedy into actionable prevention strategies. A suicide review panel provides a structured and credible way to examine emerging and complex contributors to suicide risk resulting from our rapidly changing society, including the effects of digital and social media environments on those who use such emerging technology. A review panel creates the capacity to study these influences responsibly and to recommend informed, prevention-focused responses that protect people while respecting free expression. And I see my time is up. And I'd be pleased to answer any questions you might have.
Thank you so much for your testimony this afternoon. Do you have any questions? Seeing none. Thank you. Further testimony in support of this legislation?
Good afternoon, Senator Ingerswin, Representative Meyer, and distinguished members of the Joint Standing Committee on Health and Human Services. I'm David Richmond. I'm the Director of the Maine Bureau of Veteran Services, and I'm here today to testify for LD 2108, an act to establish the Suicide Mortality Review Panel. Maine has the highest veteran suicide rate in the Northeast, and nearly 3/4 of our veteran suicides involve firearms. Despite rigorous prevention efforts, we still have a higher percentage of veteran suicides than our regional counterparts, which indicates that something is missing in our prevention model. The creation of this panel brings veteran suicide prevention efforts in Maine full circle, as the Bureau founded the Maine Safer Homes Task Force in 2019 and has collaborated for the last 4 years with Veterans Affairs and the Substance Abuse and Mental Health Services Administration as part of the Governor's and Mayor's challenges to prevent suicide among service members, veterans, and their families, and also as a recipient of the Staff Sergeant Parker Gordon Fox suicide grants. The Maine Bureau of Veteran Services recognizes the value in the formation of this multidisciplinary panel to include the Office of the Chief Medical Examiner and foresees it overlapping with the other already established panels, such as the Accidental Drug Overdose Review Panel. The panel would be responsible for systematically reviewing suicide deaths to generate actionable, data-driven, trauma-informed recommendations that strengthen prevention efforts, especially for veterans. Passage of the Suicide Mortality Review legislation would activate coordinated statewide public health mechanism for understanding suicide deaths and transforming those insights into meaningful prevention strategies. Within the first year, Maine will have a seated and trained committee, robust data processes, complete case reviews, and a concrete set of recommendations ready to inform policy, resource allocation, and system design. The Maine Bureau of Veteran Services is committed to preventing service members, veterans, and their family suicides. And the creation of the Suicide Mortality Review Board will help these prevention efforts. Thank you for your consideration. I'd be happy to answer any of your questions that you may have.
Thank you for being here this afternoon. Do we have any questions? I'm seeing none.
Thank you.
Further testimony in support of this legislation?
Distinguished members of the Joint Standing Committee on Health and Human Services, hello. My name is Kylie Wilkins O'Brien, and I reside in South Portland. I'm a licensed social worker, a public health strategist, and the individual tasked with leading Maine's suicide mortality review planning effort. I'm here today to speak in strong support of LD 2108. Public health is about learning from patterns, especially when those patterns reveal missed opportunities for support, connection, or care. In Maine, suicide deaths are recorded but not reviewed. We do not have a formal process to examine contributing factors and system-level gaps. Without that learning loop, prevention efforts remain fragmented, reactive, and incomplete. Maine already reviews child deaths, overdose deaths, domestic violence homicides, and maternal mortality because we understand that learning from loss saves lives. Suicide is the only leading cause of death without the same level of examination. This gap limits our ability to improve prevention and leaves policymakers without the information needed to act effectively. LD 2108 corrects that gap. This bill authorizes the Department of Health and Human Services to convene a multidisciplinary, trauma-informed suicide mortality review panel. The panel would bring together public health and behavioral health leaders, the Office of the Chief Medical Examiner, and community partners to look for patterns, strengthen coordination, and turn what we learn into practical, data-driven recommendations. Suicide mortality review panels operate under strict confidentiality protections and focus on system-level learning, not individual fault. They are a proven tool supported nationally by the Centers for Disease Control and Prevention, the Substance Abuse and Mental Health Administration, and the Department of Veterans Affairs. They are in use in other states with promising results. Since 2023, I've worked on suicide mortality review efforts in Oregon, Minnesota, Pennsylvania, and Massachusetts. It has been an honor to finally use my expertise here at home. In the past year, the Maine Bureau of Veteran Services secured a competitive cooperative agreement from the VA and formed the Suicide Mortality Review Advisory Team, many of whom are here today. We engaged in a rigorous policy academy and enacted an implementation plan which led us to this very moment. We are well positioned with a centralized medical examiner system, strong cross-agency partnerships, and national technical assistance already supporting implementation. What we need now is the statutory authority to formalize this work, protect sensitive data, and ensure findings are translated into sustainable prevention efforts. In Maine, suicide is the second leading cause of death for young people aged 10 to 24 and those aged 25 to 34. I have just aged out of the latter bracket. Too many of my friends are among those statistics. Every life lost to suicide leaves a ripple of deep grief and complex trauma. While we cannot make sense of these losses, we can make them mean something. And thus, I respectfully urge you to support LD 2108. Thank you for your time and your commitment to ensuring everyone in Maine gets to enjoy the way life should be.
Thank you for your testimony and for your work nationwide. Any questions from the committee?
Hi, thank you for being here. I'm sorry for your loss. How would suicides at home that have limited police involvement or EMS involvement, how would those get reported to the panel?
So we're working closely with the National Violent Death Reporting System.
Okay.
And because all of the deaths are coded by the Chief Medical Examiner's office, we would know if it was considered a suicide based on that data.
Okay. Okay. And I asked the director, will you include all suicides with or without family consent? What's been done in other states where you've worked?
In other states, it varies based on their medical examiner system. Some have coroners, some have medical examiners, some are county-based, some are centralized, and so it's varied. However, when there's statutory authority, folks can do reviews without consent. However, the review would not be complete without that next of kin interview. So it would be a limited review, if anything, and we've made a commitment to supporting next of kin during the process.
Great, thank you.
Thank you.
See no other questions. Thanks again. Let me finish this. Or you leave?
Yeah, go ahead.
Okay. Testimony and support. Welcome.
Thank you. Good afternoon, distinguished members of the Health and Human Services Committee. My name's Hannah Longley. I'm a resident of Litchfield, Maine, and I'm the owner of Dohas Wellness. I'm a licensed clinical social worker who has worked in crisis services and suicide prevention for the past 2 decades, as well as participating in the Suicide Mortality Review Committee. Throughout my career, I've had the privilege of also working a lot closely with members of the military community, including those on active duty, veterans, and individuals with combat experience. With this professional and personal background, I'm here today to strongly support LD 2108, an act to establish a Suicide Mortality Review Committee. Tragically, we lose a Mainer on average every 36 hours, with Maine leading the Northeast in veteran suicide deaths, despite numerous dedicated efforts and initiatives across our state. Suicide mortality review panels are a proven tool to provide critical insight into the underlying factors that contribute to suicide deaths. These panels allow for the systemic gathering and analysis of data, helping us to better understand the complex risk factors involved and to develop prevention strategies that are based on evidence and not assumptions. Maine has always taken pride in our creativity, our resilience, and our ability to come together to support one another. A suicide mortality review panel represents the same spirit as it brings together professionals, advocates, and communities to learn from tragedy and develop meaningful, targeted solutions that reflect the unique needs of our state. The passage of LD 2108 will ensure that the ongoing efforts are grounded in accurate information and responsive to the real needs within our communities. By passing this bill, you will help to advance interventions that prevent suicide deaths, particularly among those who have served and sacrificed so much for our country. Thank you for your time and for your commitment to improving the mental health and well-being of all Maine residents. I respectfully urge you to support LD 2108, and I'd be happy to answer any questions.
Thank you, Hannah, for being here. Questions for Ms. Longley? I'm seeing none.
Thank you.
Testimony and support in the room? Welcome.
Good afternoon, everybody. Senator Ingerson, Representative Meyer, members of the committee. My name is Melissa Gattine, and I am here on behalf of Maine Health to testify in support of LD 2108. I am the project director of a federally funded Zero Suicide initiative. Zero Suicide is an evidence-based framework for community and hospital systems that is responding to patients who are experiencing suicidal thoughts and behaviors. It has been demonstrated to significantly reduce suicide deaths and attempts in the communities where it is implemented. A common myth is that only people who have mental illness think about, attempt, or die by suicide. According to the Suicide Prevention Resource Center, only 1/3 of suicide decedents had a depressed mood at the time of their deaths, and less than half had a current mental health problem. If we only look at the deaths of individuals who had a mental illness or were in treatment at the time of their suicide, we are missing more than half of the story. We need to broaden our focus to ensure we are investigating and learning from all suicide deaths. Suicide deaths that occur for someone served by a hospital or licensed agency are reviewed by organizational leadership with the intent to identify areas of improvement. The outcomes of these reviews live in discrete silos within the organizations, so knowledge gained from these events has extremely limited impact. A statewide suicide mortality review board will bring together information from across the state, including those that happened when there was no active medical or mental health treatment. One of the known risk factors for suicide attempts and deaths is having a connection to somebody who has died by suicide. According to the CDC, for every suicide death, there are approximately 135 people exposed, meaning they have a connection personally, professionally, or emotionally to the person who died by suicide. Putting this into Maine figures, in 2023, there were 274 suicide deaths. Therefore, there were over 36,000 exposures. Every year, the number of people at risk in our state grows exponentially. Suicide is a complex problem, and there's no single initiative that is going to shift the tide. The development of a suicide mortality review board is a crucial step in identifying the network of solutions needed to reverse the current trajectory in suicide deaths. We need to support decision-making with meaningful information about why people are dying by suicide in our state. Thank you, and I'd be happy to take any questions you have.
Thank you. Thank you for being here. Questions for Ms. Gatine? I'm seeing none. Testimony in the room in support? Anyone on Zoom, Sophie? Okay. Adam Bloom Pykopoulos. Good afternoon, Adam.
Good afternoon, Representative Meyer. Good afternoon, Senator Ingerson, Representative Meyer, and members of the Committee on Health and Human Services. I apologize for not being able to be there in person today. My name is Adam Bloom Pykopoulos, and I'm the Executive Director of the Alliance for Addiction and Mental Health Services. I also volunteer on the board of the American Foundation for Suicide Prevention's Maine chapter. And as many of you know, suicide prevention is an issue extremely close to my heart. On behalf of the Alliance, I'm here today to speak in strong support of LD 2108. Suicide remains one of the leading causes of death for children, adolescents, and adults across Maine. As you've heard today, suicide is the second leading cause of death for Mainers between the ages of 15 and 44. Further, Maine's suicide death rate is the 16th worst in the nation at 18.5 deaths per 100,000. These data are provided by the American Foundation for Suicide Prevention, and I believe I've attached a copy of that fact sheet to my testimony that I submitted online. Addressing this issue requires not only high-quality prevention and intervention services, but also a systematic understanding of why these deaths occur and what can be done to prevent them. LD 2108 would establish a first-of-its-kind suicide mortality review panel in Maine. These panels are a public health strategy that are evidence-based and are used in countless other states to examine the circumstances surrounding suicide deaths and identify trends, gaps in services, and opportunities for meaningful prevention. A panel of this kind can help us improve collaboration across systems, inform data-driven policies, and generate actionable recommendations to target intervention efforts and strengthen the entire behavioral health continuum to meet Maine's growing needs. As the state in this panel considers composition of the panel, I know the Alliance would be honored to represent the voice of community behavioral health providers on this important issue. We're also incredibly grateful for Representative Stover for bringing this legislation forward, and we respectfully urge the committee to support LD 2108. Thank you for the opportunity to provide testimony virtually today, and I'd be happy to answer any questions.
Thank you for being here today. Questions from the committee? Seeing none. Have a good day. Testimony in opposition here in Test. Are we having issues over there?
Lost Abby.
It looks like we lost Representative Griffin.
I see.
Okay. So testimony neither for nor against, but with additional information for the committee to consider. Seeing none. Questions, requests for additional info from the committee to our analyst? Seeing none?
Could we just have a short corner caucus, please?
Certainly. We'll take.
Did you have a? Oh, I'm sorry.
The question for the analysts would be, other states have this review panel. Would we have access to some of their data to what they have learned?
I'm seeing lots of knowing heads shaking yes. Okay, corner caucus, 5 minutes. Okay, we're back. Senator Nangle.
Clearly, this testimony was difficult on some people, and I'd like to honor those who have been lost to suicide in the last year with a moment of silence.
Thank you. Thank you, Senator.
Thank you. In view of all of the testimony we've heard today and everything, I'm making a motion that we go into work session for LD 2108.
Second.
Okay, there's a motion and a second to go into work session. All in favor?
Just one note about this bill before you vote on it. It does have a confidentiality provision. There's a statute that requires new confidentiality provisions to be reviewed by the Judiciary Committee before they're reported out. So I think you can do a vote today. If something comes up in Judiciary and they have some concerns about any of the language in that provision, you could just reconsider that, just looking at that section of that bill. But other than that, I did not see any cause for concern with the bill.
Thank you, Sam. Appreciate that. Senator. Go ahead.
I'll make a motion not to pass.
Got a motion and a second from Representative Daigle. All in favor? Thank you all. Thank you, Sarah.
Okay, well, go down. Next up on the list is LD 2123, an act to improve dental care access for children by modifying the main care reimbursement methodology for the provision of anesthesia for certain dental services. Presented today by Speaker Fecto, the bill's sponsor.
Okay, good afternoon. I get to spend a lot of time with you all this session, it seems.
You are.
Senator Ingerson, Representative Meyer, and esteemed members of the Health and Human Services Committee. I am Ryan Fecto, Speaker of the House. I have the privilege of representing my hometown of Biddeford, and I'm here today to present LD 2123, an act to improve dental care access for children by modifying the main care reimbursement methodology for the provision of anesthesia for certain dental services. I am sure it's no secret to the committee that many families covered by main care struggle to find dental providers. Providers who accept main care often have long wait lists, and because they are harder to find, families may face significant travel times to access services. This bill intends to alleviate just a bit of that suffering. Across the state, many children on main care lack a dental home, meaning they do not have a dentist they see regularly for cleanings or other preventative care. Without this routine maintenance, curable issues, things like cavities, turn into surgical events. This leaves families with no option but to seek care elsewhere. Luckily, providers across Maine are rising to meet the need, offering restorative dentistry through ambulatory surgery centers. I was approached by one of those providers, Dr. Michael Dowling, who opened his own ambulatory surgery center for children, 207 Pediatric Dentistry in Yarmouth, after experiencing the significant wait times for operating rooms at hospitals. But the procedures needed to treat severe dental issues require anesthesia, and the hourly rate that providers are reimbursed by main care for these anesthesia services is less than the hourly rate for an anesthesiologist. This forces the dental provider to take money from the dental work to cover the cost of the surgery, leading to a large gap between demand and procedures that can actually be done. These providers, like Dr. Dowling, are working hard to make the lives of children better, but the current reimbursement rates for main care are making it challenging to operate their businesses and provide the dental care that Maine kids need. This means there is a backlog of children on waiting lists, many of whom are waiting months or even years to receive services, suffering with tooth pain. LD 2123 proposes a targeted increase to main care reimbursement rates, increasing the rates for anesthesia services provided to children at ambulatory surgery centers, as long as those centers cover at least 50% main care patients. As a result, these centers will be able to continue their operations, increase capacity, and reduce wait times. Currently, we believe this will help 2 ambulatory surgery centers in the state help more children, but we also believe that fair reimbursement rates will incentivize other centers to create a sustainable payer mix of main care and non-main care patients with the hope of expanding access statewide. So even though it may look like a small bill, it is an important one too, and is a strong tool that will increase access to dental care. I will also note that this bill was drafted as an act to allow the committee for more flexibility should they wish to amend it. While this bill is currently focused on children, I would also fully support an amendment to include Mainers of all ages based on testimony from others and the will of the committee. Access to care is critical. You all know that. We know that this bill is only part of the solution. We must also work in tandem on upstream solutions like this committee did in passing LD 1746 last year to increase access to preventative dental care so that children don't need surgery in the first place. But this is an important step towards making sure that children with urgent needs can access the care that they need when they need it most. Fair reimbursement means a healthier Maine, and together they create a Maine where no matter your income, you can live a life you deserve. I'm proud to sponsor this bill. I urge you to pass it. Thank you for the opportunity to present my testimony. And I'll just add that this is an issue that hits pretty close to home for me. I was in middle school when I was in the lunchroom one day and took a bite out of a Rice Krispie treat, and with it went one of my molars. And my parents didn't have access to insurance. I was very fortunate that my aunt happened to work at an oral surgeon who agreed to perform a root canal on my tooth at no expense to my family. But this is reality for a lot of kids, right? They are suffering through pain and unable to get the care that they need because they don't have access. And I think we should work to solve that issue if we can. So appreciate your time and happy to answer any questions.
Well, thank you, Speaker Fecteau, for presenting this bill to us this afternoon. Do we have any questions for the speaker? Yes, Representative Daigle.
Yeah, as a provider for many years, I've been on that end. When you mention 50% main care patients, do you mean like 50% of the patient pool would be main care? Is that what that implies?
Yeah, I believe the intent is that there'd be a mix of 50% main care and 50% private pay in order to be eligible for the increased reimbursement.
The reason I ask the question is from a provider point of view, it's really hard to understand how a provider could have 50% main care and still stay afloat. This is why I asked the question. So
And I think we'd be open to working on that to figure that piece out.
all right, thank you.
Any further questions for Speaker Fecteau? Yes, Representative.
Thank you, Mr. Chair. Thank you for this bill, Mr. Speaker. Do you have a sense of how many people are on the respective wait lists for requiring sedation?
I'm not exactly sure the numbers, but I'm sure there are folks behind me who have a sense of the list.
Thank you.
Thank you. Appreciate it.
We have any sponsors in the room? I think we might have. Oh, I saw one who would like to testify to this bill. Oh, no, I saw Representative Boyer, but I guess it was something else.
I've gone back to her committee.
Any testimony in support of this bill?
Senator Ingerson, Representative Meyer, and members of the Committee on Health and Human Services. I submitted testimony online already. My name is Michael Dowling. I live in North Yarmouth. I'm a board certified pediatric dentist practicing at 207 Pediatric Dentistry in Yarmouth, and I serve as medical director of the Maine Dental Surgery Center, also in Yarmouth. I want to begin by thanking Speaker Fecteau for sponsoring LD 2123. I also want to take a moment to recognize the people who do the hard work at Maine Care every day. I have a tremendous amount of respect for the work they do in a very difficult system. We all know that the people who work at Maine Care care deeply about the patients it covers and want them to be able to get the care expeditiously, much like we all do. This bill is about giving them the relatively small resources necessary to effectuate significant change. About 2 years ago, several dental providers and advocates appeared before this committee to describe the state of oral health care access in Maine, particularly for children insured through Maine Care. Many of you here were at that discussion. At the end of that hearing, this committee asked us to come back with solutions. I'm here today because LD 2123 represents an integral part to complete one of those solutions. To give you an idea of the depth of the problem we face in dental access for kids requiring treatment under general anesthesia, my office ran a report of what town patients on just our surgical wait list live in and who they're represented by. Representative Meyer, you are the only one on this committee, by virtue of geography alone, who does not have a constituent currently on our wait list or who has not been recently treated in our center. I've spent long enough in dental policy to understand the landscape we're working in. I know this bill carries a fiscal note, But before we focus on the cost, let's talk about what that investment actually buys the people of Maine. For less than $30,000 this fiscal year, approximately 200 children won't cry themselves to sleep in pain every night because they finally received dental care at the Maine Dental Surgery Center. I spent my morning today treating those children, and if I weren't here testifying, I'd be spending my afternoon doing the same. My associate is currently covering those patients so I can be here. Mind you, an associate I was able to attract to Maine from Boston with the offer of ready access to an ASC directly across the hall from our office. Let me give you a snapshot of just one ordinary morning in our office. I didn't have to cherry pick this day. It's just an everyday for us. My first patient was a 4-year-old referred to us last February. Her family didn't come to our appointment today because they forgot of their arrival time, even though we talked to them about it yesterday. While this bill won't fix that problem, cases like this represent a significant cost to us, both in lost revenue, not to mention lost treatment that another patient could receive. My second patient was 5 years old, referred to us last June. Today, he needed 4 fillings, 4 extractions, and 8 crowns. My third patient was also 5 years old, referred to us last May. We referred to treat her in the dental office. We tried to attempt to treat her in the dental office with sedation, but that was unsuccessful. Today, she needed 8 crowns, 6 pulpotomies under anesthesia. While I'm here, Dr. Shaughnessy is treating 3 more children with similar needs. Dr. Dale can speak to the clinical severity of those diseases. What I want you to focus on is this. These are very young children who waited close to a year for definitive care. Until recently, that wait was 18 months. We're drastically reducing wait times, and we have capacity to do much more. What made that possible is our Joint Commission accredited ambulatory surgery center. My team recognized that hospital operating rooms could not, or to be frank, would not absorb the volume and payer mix that our dental patients needed, especially patients covered by MaineCare. So in response to the challenge issued by this committee, we built our own operating rooms. But there's a problem. While MaineCare reimburses roughly 40% of typical commercial dental fees, we've accepted that reality and found ways to barely make it work. Anesthesia reimbursement rates, however, is different. At current rates, anesthesia services are a net loss on every case we see. Even with a facility fee we're able to bill as an ambulatory surgery center, we lose money every time we treat a patient under general anesthesia. To make that system function at all, we're forced to subsidize anesthesia costs with our already discounted dental reimbursement. That's not sustainable, and that's not how the system's supposed to work. As long as reimbursement rates stay at their current level, we can't open our doors to outside providers. That's the most important point I want to leave you with today. We have pediatric dentists, oral surgeons, endodontists, periodontists, general dentists, public health dentists from across Maine asking us to use our operating rooms. They're telling me explicitly that if they can use a facility like ours, they can accept more MaineCare patients and reduce wait times. But with current anesthesia rates, every case that we add on increases our losses. The more care we provide, the more we lose. We're not asking to profit, we're just asking break even. LD 2123 is a targeted, pragmatic solution. For $29,993 this year and $121,429 next year, the state of Maine can dramatically reduce pain, suffering, and long delays in care for some of its most vulnerable patients. This isn't an abstract benefit. I saw it this morning, and I'll see it tomorrow. The state has a responsibility to provide timely, medically necessary care to its citizens. Right now, it's failing to meet that obligation. This bill has a proven solution to function as intended to scale. 2 years ago, you asked us to come back with solutions. The speaker has brought you what we need to make that solution viable. Please let us do that work. Thank you for your time, and I'll take any questions you have.
Thank you so much for being here this afternoon. It's a very informative testimony. Thank you. Any questions? Yeah. Representative Levelin.
Thank you, Senator. You don't have anybody that serves as an anesthesiologist in your dental place, right? You have to call outside to come in?
Correct.
And they charge you full rate? They don't give you a discounted rate of any sort?
Where the group that we work with right now is providing us the care they provide us with. They're giving us a deal on it. They're committed to what we are doing, and they're charging us less than they charge any other place.
Right. So the MaineCare rate will cover that. You're assuming it will cover that full cost of the disc. Will they continue to give you that discounted rate?
Yep. We've talked with them about what that number would look like, and it would.
Will everybody be able to do this, or just your center?
Are
there other dental offices that do what you do?
So there's another center in Presque Isle that does a very similar thing.
And where did you say you were again?
Yarmouth.
So there's one in Yarmouth and one in Presque Isle, and that's it.
Correct.
Well, that's a scary thought.
Representative Zager.
Dr. Dowling, thank you very much for being here. Also for your continued championing of this very important unmet need, healthcare need. You may not know this quantitatively off the top of your head, but sort of following on Representative Lemelin's question, do you have a sense of from other colleagues who might be, in the on-deck circle, who might, with this, if this were to pass and get funded, who might increase the amount of main care patients they see and therefore reach above that threshold, which would qualify them and increase the number from 2 to 3 to 5 to 10 or whatever? Any idea of who might be following your lead?
I mean, I think it's hard from another center standpoint. Building a ambulatory surgery center is an incredibly complex process. So I think adding on other centers might be difficult. We have at least 10 other providers that would like to come and use our space. I can't speak for the other center in Maine for what that would look like there, but we have lots of other providers that we'd like to bring in and let use our space, but we need something like this to make that possible.
And would this facilitate if, say, a hospital, hospital operating room, could that be used, or so that somebody wouldn't have, so that the care could be delivered in a site that already exists, even though it's not a new ambulatory service center?
Whether or not a hospital could meet that 50% main care threshold, I think would be an interesting question for a hospital. But I think one of the big benefits of a bill like this, or kind of the model that we're looking at, is if we can get a lot of dental patients treated in dedicated dental ASCs, we're now freeing up hospital operating rooms to treat patients that need much more advanced surgeries in those hospitals and better utilizing those resources for what they need to be there for. So we're not putting a kid that needs 3 teeth extracted in a hospital operating room. They're in my operating room instead.
Okay, thank you.
Further questions? Yes, Representative Lemelin.
Thank you, Senator. How long a waiting list are you talking about right now for dental care?
There's a couple different ways to look at it. Right now, if someone were to call my dental office and ask for an appointment, we're probably booking them out about 4 months for that appointment for an exam. And then from the time we see them, right now, fortunately, we've been able to cut down on that wait list because of our surgery center. They're probably scheduled out another 6 to 9 months for that actual appointment in that operating room. Previously, that was closer to 18 months, but we've been able to dramatically cut that down. But you also have to recognize that from the time they got that referral to see us, they probably also waited 6 months there. So it's often already that 18 months.
That's what I thought. Thank you.
Yes, Senator Engel.
A couple of questions. One, this would certainly benefit your surgical center, but are general providers able to do these type of procedures within the office that require anesthesia?
So they would be able to do those types of procedures in an ambulatory surgery center. There are typical procedures that, I do a filling in my dental office. I also do a filling in my surgery center, but the patient needs to be treated under anesthesia, so they're in the surgery center for that reason.
Okay. So this would only benefit surgical centers, not other, like I could get, if I was 15, I wouldn't be able to get anesthesia at my dentist. I would need to go to an ambulatory surgical center.
Correct. It would be at an ambulatory surgery center that would be covered. And part of that recognizes the treatment in an ambulatory surgery center involves a lot more and is a lot more expensive to render in those sites. So we're trying to recognize that difference there.
You mentioned some pretty significant dental problems with a couple of 5-year-olds. Do you think the wait that it took to get to the ambulatory surgical center was a contributing factor to those issues?
I mean,
Like needing 8 crowns?
I mean, that absolutely is a factor that the longer patients wait, the worse things get. There also is a tremendous amount of need that exists, and we will be providing a tremendous amount of care for a long time to catch up on that.
Thank you.
Further questions? Seeing none, thank you so much for being here.
Thank you
Yeah.
for taking the time.
Any further testimony and support?
Hi, I submitted testimony online. Senator Ingerson, Representative Meyer, and members of this committee. My name is Kaylee Hess, and I'm the Associate Director of the Children's Oral Health Network of Maine. Our network includes hundreds of organizations and individuals across the state who work together so that children grow up free from preventable dental disease like what Dr. Dowling was describing today. I'm on here on behalf of our whole network to testify in support of this bill, LD 2123. We are all in agreement that Maine's children deserve timely, high-quality dental care, and whether that they get that care shouldn't be limited by insurance status or bureaucratic barriers. Unfortunately, we know that children with Maine care often face significant delays or are unable to obtain necessary dental treatment, especially when anesthesia services are required. This bill helps fix a really practical problem because, as we heard, reimbursement just doesn't match the real world cost of providing these services, especially when anesthesia is involved. As I've shared with this committee before, and as you heard again today, children with Maine care always face some of our steepest barriers to care. The statistic that always stays with me that is not as nearly as compelling as the stories that Dr. Dowling was describing is that even what most of us think as the bare minimum of care, so 1 cleaning and 1 exam a year, just isn't happening for 4 out of 5 children with Maine care. When routine care is this hard to get, children who need more complex care face even bigger obstacles. You've heard in past testimony that too many children are living with pain longer than they should, having trouble eating or sleeping, missing school, and dealing with dental problems that just keep escalating instead of being treated early. We would never ask a child with vision problems to just push through without glasses, or a child with hearing loss to learn without support. Expecting a child to focus in school while they're in dental pain or have an infection is the same thing. We see every day in our network how untreated dental disease affects children's health, learning, and quality of life, and how much harder it is for families when care is delayed. I mean, you can imagine when you've waited for an appointment and then having to miss it after waiting for months. I mean, that poor family, yeah. And, we've come before you as a network to talk about early intervention in schools and community settings, and this committee has really understood the importance of that work. I have to put a plug in for LD 1746, as the speaker did, which this committee prioritized and which would bring more early intervention to kids. It's waiting on funding, and the reality is that we need solutions that bring more preventive and more restorative care to kids in order to make a dent in this persistent challenge, because as was just discussed, the problems do get worse while the kids wait for care. When the system provides the resources to treat kids, they get care sooner instead of sitting on these obscene wait lists while their disease continues to progress. Along with prevention and early intervention, this is how we start closing those persistent gaps in access to care. So we hope you'll support LD 2123 as an important step towards making sure Maine kids can get the treatment they need when they need it. With a second to spare.
Thanks so much. Got it. Thank you, Kaylee. Do we have any questions, Ms. Hess? Seeing none. Thank you.
Thank you.
Testimony and support.
Senator Ingerson, Representative Meyer, members of the committee. My name is Charlie Sultan. I'm an attorney here in Augusta, and I am general counsel to the Maine Society of Anesthesiologists. I'm also here, been authorized to speak on behalf of the Maine Osteopathic Association, which I'm also general counsel, and the Maine Medical Association. In full disclosure, I'm also a general counsel to the Maine Dental Association, but I do not appear here on their behalf today because they are ably represented. But I can't, I mean, I like to, we support Dr. Dowling's effort here to try and make the practice work. As anesthesiologists, we could wax eloquently about the main care rate that we receive, like dentists. I think we're pretty much in the same boat. But this is a very targeted effort for a special need. And in my experience here in the legislature, this is the kind of change that the Appropriations Committee finds in the sofa in the back room of the committee. So I'm hopeful that this rises to the level of need and inclusion into the supplemental budget for you guys in the coming weeks. The need has been eloquently talked about, and we certainly support any effort to make this work. I'm glad to answer any questions. I don't have written testimony because it wasn't finished, but if you want it, I can submit some, but it's pretty general.
Thank you. Thank you for your testimony. Do we have any questions? Yeah, Representative Zager.
Thank you very much. Thank you for being here. And just wondering the way this is calibrated. I mean, I love the bill. I'm just wondering about this particular, is $1,000 an hour typical for anesthesia?
No, I would I understand that in one of my clients, they measured it in units, and the ratio they came up with is it's a $14 per unit reimbursement rate for main care, whereas their private pay is $51 per unit. So that's the distinction between the rate of reimbursement. What that full cost is, I don't know.
Okay. Maybe
I'll try.
Maybe just for the work session, we can get a
see if I
sense of
can-
where this fits in with other, anesthesia reimbursement rates. I mean, there's a lot of training and, care that goes into anesthesia delivery. Fully recognize that. I just want to get a sense of how this fits in.
As Dr. Dowling mentioned, I mean, this is oftentimes full anesthesia. So it's the same kind of anesthesia care that you're going to get in the operating room. Obviously, full sedation, that kind of stuff. So very specialized, needing to monitor the patient. So.
Further questions? Seeing none.
All right. Thank you very much.
Yeah, take care. Further testimony and support.
Good afternoon, Senator Ingleson and Representative Meyer and distinguished members of the Committee of Health and Human Services. My name is Bonnie Vaughn. I'm a dental hygienist. I reside in Cumberland, Maine, and I'm executive director of the Kennebec Valley Family Dentistry Center, which is right across the river in the Ballard Center. We are a nonprofit. We are more than 80% Maine care patients. Our services include diagnostic, preventive, restorative, and extractions. Our center is located, as I said, in the Ballard Center at the old Maine General Hospital at East Chestnut Street. One of our major concerns is among young patients and older patients who need sedation. And when we talk about sedation, we're talking about putting somebody out totally because they can't seem to adjust to sit in the dental chair with local anesthesia. So it's a more severe, like Dr. Dowling was saying, it's more severe than local anesthesia. So full sedation. Previously, we've worked with pediatric dentists that had hospital privileges at Maine General in Augusta. This was discontinued in the Augusta branch. It was moved to the Waterville outpatient clinic, but that didn't solve our problem. Maine General reduced the days available and the time slots. So now we work with Dr. Mills, and he only has 1 or 2 dental slots a month that we can use. So this certainly does not meet any of the needs that we're looking at. We fully support Dr. Dowling's Maine Dental Surgery Center. We refer a lot of patients to him, and we will continue. These are very expensive centers. As you've heard, construction is significant in installing all of the gas systems. The state Maine licensing requirements are also very significant. And as you also talked about, the staffing with the anesthesiologist, the sedation licensed dentist, and the support staff. That's just the tip of the iceberg about costs for staffing. The key to maintaining some of the surgery centers is the main care reimbursement. So we would certainly support anything you can do in increasing the rates for sedation services when we have to use these services for individuals who can't have dental services under nitrous. And we do in our clinic nitrous, so we put people under that, but that's not full sedation. That just makes them a little sleepy and they don't feel the pain as much. So we do sedation in our centers for some of the kids. So thank you for your time and interest in helping Maine residents with severe dental disease. We certainly support 2123. I'd be glad to answer any questions about our services.
We thank you so much for being here this afternoon for your testimony. We have any questions? Seeing none?
Thank you.
Further testimony in support?
Good afternoon, Senator Ingerson and Representative Meyer, distinguished members of the Health and Human Services Committee. I am Teresa Cahill, and I'm the Executive Director of the Maine Dental Association, and would have gladly passed my talk off to Charlie if he would have done that for me. That would have been great. The MDA represents all dentists in Maine and is a statewide association dedicated to promoting oral health and excellence in dentistry. On behalf of the MDA, I'm enthusiastically providing testimony in support of LD 2023. My testimony is a little redundant. You've heard a lot today. So basically, I just want to point out a couple of things. I'd like to thank Speaker Fecteau for taking this on. We've been talking about this since we came to you 2 years ago. We've been talking about different ways to solve some of this problem. So I appreciate his ability and his interest in taking this on. I'd also like to thank this committee and Representative Meyer for allowing Dr. Dowling to continue his testimony beyond his time. And I want to I will make that up to you. And so the last thing a couple of things I just wanted to point out is that MaineCare has moved up their rate redetermination for Chapter 25. And it was supposed to be for next year, and they've moved it up to this year. And I believe that they will actually talk about that in their testimony. You have multiple testimonies online from other pediatric providers. I'm just going to let them speak to all of this, but I would just say that as you can see and hear in their testimonies, and sometimes contrary to some of the other things I hear in this position, we do have dentists who want to provide care to people with MaineCare insurance, and they are eager to deliver that care to children. This is a step towards that. So thank you for hearing this bill, and I would be happy to answer any questions that I may just say. Mike, can you help me out?
Thank you so much for your testimony. Yes, Representative Zager.
Thanks very much, Ms. Cahill. You may have heard my other questions, and I would love to do what we can. I think that this bill is a useful step towards fostering more delivery of care to MaineCare recipients. The bill as written is for if the ambulatory surgical center has more than 50% of its patients, not if the providers who are doing the care in the ASC have more than 50%. But what I'm hearing from your testimony is that just having access, whether it be, in Yarmouth, Presque Isle, even if they have to travel a little bit, they're willing to do it. Just having access to an ASC that has much more adequate reimbursement would facilitate their care of main care members more comprehensively and therefore deliver more care. Do I understand that correctly?
Yes, you 100% correct on that. One thing I would just say is Mike, Dr. Dowling, has 90% main care children have been seen, or main care patients have been seen in his ASC so far. And as he indicated, he has seen patients from all of your areas. The interest in his ASC has taken off. Many other specifically pediatric providers have reached out to us, reached out to him, asking how to get to be a part of that. They can't all afford. Dr. Dowling took it upon himself to build this ASC, and he built it with his own money. Like this was all his. He was so frustrated with the inability to serve the main care population. He did this all on his own and without knowing that this might be a possibility. Not everybody can do that. So, but the interest in serving patients, and I did speak with one pediatric dentist a couple weeks ago, and she told me flat out that if this could increase, she would be able to see and process the beginning parts of this treatment quicker and move it forward faster. So these wait times would definitely be decreased for children who are seeing pediatric dentists across the state.
That's great to hear.
Yeah.
Thank you.
Yeah.
Thank you. Further questions? Seeing none.
Thank you very
Testimony.
much.
Yeah. Further testimony and support. Do we have anybody on the line support testimony? Testimony in opposition? Neither for nor against this legislation. Any requests from the committee at this time? Yes, Senator Moore.
One of the things, I definitely am grateful for this chart to know that they are going to be reviewing the dental services and they moved it up to 2026, but I would like to know what the current reimbursement rate is. I think that'd be interesting to get an idea on that. And the other thing that's kind of sticking in the back of my head, at some point in time when we were looking at managed care and we talked about doing a pilot project, and I thought it was for dental services for children. And I don't know that we've ever got a report back on that as to where we stand or what's happened with that. Am I crazy, or do you remember us talking about it? So maybe if we can look into that, Olivia, that'd be great. Thank you.
Great. Further requests? Yes, Dr. Daigle.
Well, thank you for this ambulatory service. What I'd like to know is what it costs to establish such a center and what your operating expenses are as far as a percentage practice. So to make it feasible for other areas in the state to establish this, that type of data would be important.
Yeah. Yes.
I can give you some of those numbers now if you'd like those. Or I can-
Could you like come up and actually talk to us about that? And you could also, if there's anything, I mean, I don't want to take up any of your time. So you do too good a job with our children. So
No, I mean, a couple, I can give you some of the information. The current rate for main care is $151 and some cents per 15 minutes. We're asking to increase it to $250 per 15 minutes. The pennies per 15 minutes, I don't know that offhand, but it's $151.
that's interrupt. Is that 15 minutes under sedation? So if they add,
Correct. So
per
from the
block.
time that they're put to sleep until the anesthesia provider leaves them. And it's billed in a fraction of a unit, basically. So if it's 22 minutes, we're billing for 22 minutes of time. That doesn't include the time that our nurses spend pre-oping them, how long a nurse spends with them post-op until they're ready to go home. That's just how long the anesthesiologist is with them, or the anesthesia provider is with them. The cost of building a center like that, in a leased space, about $2.5 million. Cost of running it, the facility fee basically means we break even on providing that care. Anesthesia we lose money on currently. So there's not much of a margin there. Where our business model works at all is the dental care that we're able to provide in that time. But like Teresa's saying, currently we've treated about 90% of our patients have been covered by main care. In my dental practice, about over 50% of them are covered by main care.
Further questions?
I've got a quick question. Thanks for being here. Good to see you again. And you listened when we said, please come back.
We've been working on this for a while.
We gotta be careful what we ask for.
Did
right?
we listen?
I hope so.
I think so. Available services over the border in New Hampshire. I'm wondering why there's no wait list in my area, and I'm wondering, are patients going across into New Hampshire?
There probably are wait lists in your area, just your constituents haven't come to see me. There's other pediatric dentists in your area, so they're probably seeing those providers, just they haven't ended up in my office.
Yep, gotcha.
Anything else? Well, thank you. Thanks for being here so much. Any further requests from the analysts for the work session? Seeing none, that brings our hearing on this bill to a close. And we will now begin the hearing for 2136, an act to support victims of trafficking in Maine in response to federal funding cuts, presented by our own Senator Nangle of Cumberland. When you're ready, Senator.
Thanks. I hope it was timely and helpful. Yeah. Great, thanks, Alex. I really appreciate your support.
Senator Nangle.
Thank you. Senator Ingerson, Representative Meyer, and esteemed colleagues of the Joint Standing Committee on Health and Human Services. My name is Tim Nangle. I proudly represent Senate District 26, which includes the communities of Windham, Raymond, Casco, Fry Island, and parts of Westbrook. Thanks for the opportunity to present LD 2136, an act to support victims of trafficking in Maine in response to federal funding cuts. This bill is a direct response to an unexpected federal funding delay that is disrupting services for survivors of human trafficking here in Maine. For more than a decade, Preble Street's Anti-Trafficking Services Program has relied on funding from the U.S. Department of Justice's Office for Victims of Crime. That funding expired last fall, and the next round of federal funds has been significantly delayed, leaving a gap in services at a time when survivors are actively seeking help. As a result, the largest anti-trafficking service provider in our state has had to begin a waiting list for survivors. These are individuals who have experienced severe trauma and exploitation and are trying to find safety and stability. A delay in support at this stage can have serious consequences, and the assistance provided through this program is practical and flexible, helping people with housing, food, medical and mental health care, legal needs, and relocation when necessary. In many cases, meeting these basic needs is what allows someone to leave an unsafe situation and begin rebuilding their life. LD 2136 provides a one-year bridge to replace the lost federal funding allowing these services to continue while the federal process catches up. This is not a new initiative, but a short-term step to prevent a proven program from being forced to scale back at the worst possible time. More broadly, this bill reflects a new and troubling reality. Maine can no longer assume that even long-standing congressionally approved federal funding will be delivered on time or at all. When the federal government is derelict in its responsibility to follow through on commitments that communities depend on, the burden falls on states and on vulnerable people who are already in crisis. I want to emphasize that again. In this case, survivors of trafficking are being waitlisted for help because funding was held up with no explanation. When that kind of instability puts people at risk, we have a responsibility to step in and prevent harmful and unacceptable gaps in care. LD 2136 is a targeted, time-sensitive measure to make sure survivors of trafficking are not turned away simply because of an administrative failure at the federal level. Thank you for your consideration. I'd be happy to answer any questions. There is a representative from Preble Street here who can speak much more in depth into the services they provide.
Thank you, Senator Nangle, for this bill. Do we have any questions for the senator? Yeah, Senator Moore.
Thank you for bringing this forward. Is Preble Street the only one that is not getting the funding, or is there other organizations as well?
Preble Street is the largest provider
Okay.
of this care. They would know who
Else might be affected.
else might be affected by this.
Thank you.
Thank you. Thank you so much.
Okay, thank you.
I'd like to invite, if there's no co-sponsors I don't see, I'd like to invite Preble Street to come on up.
Good afternoon, Senator Ingerson, Representative Meyer, and members of the Committee on Health and Human Services. My name is Haley Varuso, and I have the privilege of serving as the director of our anti-trafficking program at Preble Street. The mission of Preble Street is to provide accessible, barrier-free services to empower people experiencing problems with homelessness, housing, hunger, and poverty, and to advocate for solutions to these problems. As Maine's largest dedicated anti-trafficking program, we serve over 100 survivors of trafficking across the state of Maine, working alongside them as they reclaim their lives. I am here today to urge you to support LD 2136, a bill that would fill a critical funding gap on a one-time basis to support adult survivors of human trafficking in Maine. Since 2013, our program has relied upon federal funding from the Office for Victims of Crime to provide case management to survivors of trafficking and assist them with meeting their basic needs. Typically, applications for this funding open in April, but in 2025, the call for applications was delayed without explanation until the end of December. This disruption to the standard grant cycle forced us to significantly scale back the services we can provide and implement a waitlist, which is not our usual practice. This waitlist has averaged about 20 survivors since October of 2025. OVC grant funding has had a positive impact on the lives of so many survivors we have served. During our most recent 3-year OVC grant, which ended in September of last year, we served 157 survivors of trafficking across 7 Maine counties. During the same period, we received nearly 350 program referrals, indicating that this funding source alone supported 45% of the survivors we served. In addition to covering staff time, we also allocate OVC funds towards relocation costs, rental assistance, food and clothing, and mental health services for survivors of human trafficking. Because traffickers leverage their victims' unmet needs to keep them trapped in exploitative situations, it is critical that our team be able to provide survivors in accessing food, shelter, and other necessities outside of a trafficking victimization. When our most recent OVC grant ended in September, we lost the ability to provide that kind of support to many of our clients. Human trafficking is an economic crime, robbing people of their freedoms and opportunity to financial security. It is imperative that we can meet those needs while working along survivors to support them in stabilizing their lives. I'd like to share just one of the many examples of the impact of this loss of critical federal funding. Our program was unable to provide transportation assistance to a survivor working towards independence. As a result, she missed a scheduled job interview, an opportunity that could have moved her closer to financial stability and long-term safety. Public transportation and walking were not viable options due to serious safety concerns in her community, leaving her with no safe way to attend the interview. This single gap in services illustrates how funding cuts create immediate, real-world barriers for survivors of trafficking, undermining their ability to secure employment and rebuild their lives. One-time funding through LD 2136 would enable us, thank you, to continue supporting survivors of human trafficking despite the federal funding lapse. We urge you to pass this legislation so that Maine survivors can continue to find dignity, safety, and healing. Thank you for your time, and I'm happy to answer any questions. Thank you.
Thank you so much for your time here today.
Sure.
Do we have any questions? Yes, Senator Moore.
Thank you. And I'll ask that same question. Are there other organizations similar to Preble Street across? I know you're saying you handle 7 Maine counties. Are there others throughout the state that also do the same stuff?
Yeah, so anti-trafficking work is a collaborative initiative across the state of Maine. It's 7 counties that this funding source serves. Our program serves all 16 counties here in Maine, but we work in tandem with other organizations across the state.
That work with that.
Yeah.
And how much is your, another question?
yes.
Please. How much was your total funding typically, and then what that versus what you actually received this go round?
So we have lost $950,000, which is a 3-year grant cycle with the Department of Justice.
Okay. Thank you.
Sure.
What other funding sources besides OVC?
We receive funding through HUD, Housing and Urban Development. We have a private grant through the Howard Buffett Foundation, and we have one other funding source through the Office for Victims of Crime, but that's geared towards minor victims of trafficking exclusively.
Yeah. And state funding?
We do not receive any state funding.
Any state funding,
None.
right? So the OVC was really important.
Incredibly.
And that's 45%, it sounds like, of your services were OVC funded.
That's exactly right.
Okay. Further questions? None, thank you. Further testimony and support? Are there any Zoom testimony in opposition to this legislation? Testimony neither for nor against? Any request from the committee members for the analysts for the work session? Seeing none, I'll end the hearing. And I'll make a motion to adjourn.
No.
You got stuff? Sam's got some stuff? Okay, we're not adjourning.
Take that back.
Am I eager?
Take that back.
I want to step outside.
Never feel less popular than when I have language reviews at the end of a busy day. I'll just wait a second for Sophie to have a chance to pass those out. So the 3 that I'll be doing today are LD 1772, which was the Healthy Maine Stabilization Fund bill. Its companion 1658, which is the also the Fund for Healthy Maine, but the tobacco tax revenue. And then the Progressive Treatment Program Fund bill, which was LD 1989. So I have all 3 of those here for you. And I've also got the fiscal note for 1658. So which one do you have first? Okay, so that's where I'll start. So as you'll recall, you had voted to pass this bill, stripping out the commission that was created in the draft of the bill that you had held the work session on. So that left the creation of the stabilization fund. Because that really narrowed the focus of the bill, I'm proposing a new title for the bill. An act to establish the Fund for Healthy Maine Stabilization Fund. This is pretty straightforward. So there is still an emergency preamble on this bill. The language of the bill is essentially the same as what you had seen previously. There is a change that I did want to point out under use of funds. This is on the second page towards the bottom under 3. The first 2 uses are the same. The third use there had been language about supporting the work of the commission that, of course, is no longer there, so that language is gone. There is some language there that I put in. Third, if funds remain following the uses described in A and B for any allowable health promotion activity described in section 1511, subsection 6, that's the Fund for Healthy Maine. That language was there before. And or any health-related research and planning activities to supplement and interconnect current efforts among state agencies and stakeholders. I'd understood that there was some desire for some placeholder language for some research related use of the funds at the discretion of the committee. So I put that in there for you to look at. You can tell me if it's okay.
I'm in agreement with the inclusion of that language. Yep.
Okay, good. So that's 1772, and I'll do its companion, 1658. Oh, you have 1989. Oh, you have 60.
Oh, I'm sorry. Yes.
Oh, no worries.
Looking at AP.
Oh, yeah, the House paper. Yeah. So this one has gone through the revisor's office because it was pretty straightforward, and I wanted to check on, just make sure we had everything all set with the way that the tax allocations went. So they did have one suggestion, or they pointed out one thing, which had to do with the time at which the money was transferred. So it before had said that the money should be transferred on December 1st. Revenue was a little worried about that. The comptroller, or I'm sorry, it had said the transfer would take place in June before, and they were a little worried about that timing because it's right at the end of the state fiscal year. They said that isn't the best time to do a transfer. They recommended either a December date or an ongoing transfer. I did speak with Carol Kelly about this to see if there was anybody who had been involved in the drafting of this had any concerns about that. And the feedback I got was that an ongoing transfer would probably be simpler. So that's what I wrote in there, but totally up to you if you prefer a set date in December was the suggested time. Could certainly do that, or we could keep it with an ongoing transfer kind of as you go. Okay.
Question then. So the wording in here, though, where we are referencing the June 30th dates.
So it's just the fiscal years. That's just to
Just at the
describe
end
the
of the fiscal year,
years.
so, but the ongoing transfer would be,
Yes, as the tax revenue was received, it would
it would
go
automatically
straight
be going
to-
into,
yeah,
okay, I just
yeah.
wanted to understand
Yeah.
that myself. Okay, sounds good.
And you have a companion fiscal note. I talked to Rob about this fiscal note. Rob is our new OFPR analyst for this committee. I think you'll probably meet him very soon. So this unfortunately it's a little hard to read. Like you look at this and you're like 27 million what? So it's budget neutral. So it's just showing that the money is going to go, the tax revenue is going to go into the Fund for Healthy Maine instead of the general fund.
Yeah.
I know having the other special revenue funds line in the middle there, like it's a little confusing. It's just showing the pathway of the funds, but it is ultimately it is cost neutral. Because it's just moving where those funds are. It does still have to go to the table, I believe, because there's a fiscal note on it, but there's no extra money that's needed with this.
Which is great. My only thing is I'm thinking to myself is that unless they were earmarking that general fund money to go somewhere else, that would be the only gotcha on the table. But anyway, just a comment. This looks good.
Last one, we've got the PTP bill. So this, there had been a number of changes that you had wanted to make to this. So there was a request for an emergency preamble. You'll see that there. And then, of course, the change from the use of the funds by private entities switched it to be the enumerated private entities that are able to move for a PTP, as well as their attorneys. Instead of the renewal language, we're using the extend language to be consistent with current statute. And then setting a cap of $3,500 annual. And then that language at the end, that reimbursement is subject to the availability of funds. So that's that.
Any questions on this?
The other questions that I had was there were a bunch of centers that used to renew, and now it's called extension, and some that would initiate it. And that number had decreased significantly, different sources or sites in Maine, I should say. Do we have any idea what and why this happened?
So I don't have numbers, but when we did the work session, the department had answered, there was a list of questions they had answered about those changes to the PTP process. And there were some changes around what cases the Office of the Attorney General was handling. And that was specifically around cases where an individual had been in a state facility, had been released, and wasn't followed anymore by the physicians who at that state facility. They were instead followed by an outpatient ACT team. And so I think there was some concern over whose job that was to initiate those renewals then. And what we heard from the department is that ACT teams can initiate those renewals. They don't need the state hospital to do that. But it would be the state hospital, or it would be the ACT teams that were pursuing those renewals instead of the state hospital. And of course, the OAG would not be representing individual ACT teams that are not affiliated with that are not part of the state hospital. Yeah.
Okay, thanks. Any further? Okay.
Sounds like we're okay with all this.
Okay.
Yep.
These babies go.
And a reminder that tomorrow morning, we're going to be doing the GA work session. So if you have things that you would like to propose for that, we will go over that tomorrow, and I'll walk you through that.
Binder home, bring it back.
Yep.
All right.
Thank you.
Good.
Thank
We
you,
done?
Sam.
Thank you, Sam. I will now entertain a motion to adjourn.
Motion to adjourn.
All those in favor? See you tomorrow morning at 10 for GEA review.